So in trying to organize this material, I came up with a lot of different ways, and it's mostly chronological. It's mostly pretty well organized, but I'm not sure how if it's the right way or not. But this is the way we're going to do it. I'm going to start with a brief history of the treatment of traumatic stress, and going to do that through the lens of the 19th century, the 20th century, and then, as the title of this course is moving us into the 21st century. And there's really significantly different evolutions and different paradigms, zeitgeists, understandings of trauma to get us to here in the 21st century. And I just want to show you, like, there's no way that I'm going to be able to do an exhaustive history. It would be the whole course. But I want to hit some of the primary folks upon whose shoulders we are standing to bring you this material. And we'll start with the picture there of hysteria, which is what trauma was called before it was called PTSD. We had the diagnosis of PTSD in 1980 with the publication of the DSM-3. Before 1980, it was called a whole bunch of things colloquially: shell shock, combat fatigue, railroad spine, lots of different kind of colloquial titles. But mostly, when the diagnosis shook out, it was generalized anxiety for men and hysteria for women, commonly. And kind of moving around the circle there. That's a picture of Odysseus, and Odysseus is a wonderful metaphor for the healing of combat trauma. For those of you that work with combat survivors or even law enforcement officers, I urge you to pick up Jonathan Shea's, both of his two books actually, Achilles in Vietnam and Odysseus in America. They're both masterworks. Achilles in Vietnam it talks about the kind of different components, the specialization of working with folks who are combat survivors, and what combat does to a survivor that's a little bit different than other trauma. And Jonathan Shea very elegantly tells that story through the lens of the Iliad, through Achilles. And it's really cool. But what's even 10 years later, he wrote Odysseus in America, and it's, in my opinion, his masterwork. And it is the story of what it takes for a combat veteran to get from the field of combat to get home, and every sense of that word, what it means to get home. And he tells the story using the trials of Odysseus as metaphors for what it takes for a combat veteran to get back home. And that's really, Homer really, 2,000, however many years ago, 2,300 years ago, that Homer wrote very elegantly about the impact of trauma. So that's really kind of some of the first historical writings that we have about the impact of trauma. And then continuing around the clock at the 2 o'clock position is Jean Charcot Pierre Janet, and Charcot is underneath of him at the 3 o'clock position. And those two folks are really the dinosaurs of traumatic stress treatment. They were in Paris, early 1800s, and working with hysteria, working with trauma. And the treatment du jour then was convalescence. Is that they had, people that had trauma had them laying around in psychiatric hospitals. And what Janet did was began to activate, get them engaged, get these men and women participating in their lives, cleaning their living spaces, cooking their own meals, engaged in gardening and calisthenics, and activated them, started having them burn some energy. And he was doing individual therapy by integrating dissociated memory components through a woo-woo technique then called mesmerism that evolved into hypnosis. So using a regulated low-energy body state to be able to do exposure therapy and integrate fragmented memories. which is where we finally got into in the 21st century. And he had that, 140 years ago. And it was publishing about it. But then the person in the middle there, you all recognize as Sigmund Freud and Joseph Breuer, his partner underneath. Freud came to, my French is really bad. I'm from southern West Virginia, so you can't expect me to do very good French pronunciation. Salpêtre in Paris was where Pierre Janet was. And Freud came and got really jazzed about the work that they were doing. And that was 1885, I think. And he went back to Vienna after being there for a little less than a year. And he took what he learned from Janet and he took it to the Vienna School. And you'll remember that Freud initially explained hysteria as sexual abuse. His seduction hypothesis was that the reason why all of these people had hysteria is because they had histories of abuse, particularly sexual abuse. And what was interesting is that the Vienna School rejected that. A bunch of old white guys sitting on the board of the Vienna School, they said, there's no way there's that much sexual abuse in Europe. And you need to come up with something else. And Freud, I think, not wanting to lose his seat at the table, famously in 1889 recanted his seduction hypothesis. But Freud was originally a traumatologist, which is kind of cool. But then he kind of proliferated this drive theory. And that became, it caught on fire. It eclipsed everything else that was being done in Europe. And the birth of psychodynamic psychotherapy, psychiatry was born, and everything that was published up until the mid 20th century was psychodynamically leaning. And so all Janet's work got buried underneath of that. Nobody paid any attention to it until it was rediscovered in the early 1980s. Anna van der Hart and Bessel van der Kolk began writing about what we had these effective treatments that were non-abreactive 100 years ago, and they've been lost to science, and it's one of the great travesties of our field, is that, what would we have done if we would have been aware of that and known that we had ways of healing trauma that didn't hurt trauma survivors and that was elegant? How would that have changed our field? That's an interesting question. One little interesting footnote is that Pierre Janet in 1909 publicly indicted Freud for plagiarism. Freud ganked his work, basically stole a lot of his work without attribution. At least that's what Janet alleges that he did, and it seems to, it certainly fits looking retrospectively that Freud would have come forward with that. So there's the 19th century. Now, moving into the 20th century, as I said, there's no way this is an exhaustive list. There's just too many people. But these are the people upon whose shoulders I and we are standing to bring you this material. And I want to start at the 1230 position, and that is Charles Figley. And Charles was my major professor, my dissertation chair. I went to Florida State to study with Charles. Charles is one of the primary reasons why we have the diagnosis of PTSD. He was a Marine in Vietnam, served, came back, got his doctorate at Purdue, and in the mid-70s did a huge qualitative study with returning Vietnam veterans and published that. He called it the Vietnam Stress Syndrome, and that information was taken to the American Psychiatric Association, and in 1980 was the coming forward of the diagnosis of PTSD. And Charles was an advocate and a big reason why that happened. He was the first president of the International Society for Traumatic Stress Studies. He was the first editor of the Journal of Traumatic Stress, and I'm really honored and privileged to be standing on his shoulders. Well, he's one of the giants upon which that I'm able to bring this material, and I clearly would not have had a doctorate if it weren't for Charles. 2-part support and 1 part foot to butt was what he did for me. And I'm really, really grateful for his presence in my life. Kind of moving on around the circle, we have Herbert Benson at Harvard in the early 60s. And what Herbert Benson did was establish the potency of the relaxation response. And he began, and that's, I don't know if you're going to have to blow up that slide a little bit. That's the Dalai Lama beside him. And he began working with transcendental meditation and with other methods of relaxation at Harvard in the early and mid 60s. And he was applying that relaxation skill to transdiagnostically with kind of folks with every psychiatric disorder that he could find. And what he found was effectiveness in helping people as they were able to achieve and sustain the relaxation response, that their quality of life got better, their symptoms abated. And nobody much paid a whole lot of attention to him, which is unfortunate. We are now. Underneath him is Francine Shapiro. Some of you will recognize her. Francine Shapiro is the developer and founder of the most researched treatment in the history of humankind. Psychiatric treatment is eye movement desensitization and reprocessing. I was trained in EMDR early on in the early 90s. Went through level 1 and level 2 at Florida State in 1997 or 1998. I was an instructor and was an instructor of EMDR for many years and taught a whole lot of folks. And I'll go ahead and say this straight away at the beginning of the training. If you're working consistently, if 50% or more of your clients are trauma survivors, and if you've begun yet using the ACE, the Aversive Childhood Experiences Scale, and you are using that scale regularly, what you're finding is that pretty darn near 100% of your clients, no matter what they come in for, when you do the ACE with them, you find they have an ACE score of at least 1, that they are trauma survivors. But if 50% of your clients, through the methods that you use for assessment, are recognized as trauma survivors, and if you are in the first 3 quarters of your career, you need to go ahead and bite the bullet and get EMDR trained. EMDR is not a panacea. It's not the only method, and the stuff that you're going to learn in this course makes EMDR work a whole lot better. But EMDR is the only method out there that I'm aware of, the only one that's had good empirical research done, that allows you to work with multiple traumas inside of a single session. All the other EBTs, evidence-based treatments, all the other ones, to be able to resolve criterion B symptoms, the flashbacks and the nightmares associated with trauma. What you have to do is you have to go back to the trauma. You have to circumscribe that particular memory, and you do a narrative process through that memory and integrate and desensitize the pieces of that trauma that are intruding, causing the symptoms. And you know, you may roll the dice and hit the target right on the head and resolve that in one session. However, when you've got people that you're working with that have episodic trauma, things like childhood sexual abuse, childhood physical abuse, torture, human trafficking, when folks have had, you know, episodic continual trauma, then narrative's a pretty clunky way to do it, because you're not exactly sure where the intrusive symptoms are coming from, and you start circumscribing and doing these trauma narratives, and you got to keep doing them until you hit the one that is causing the intrusive symptoms. So what's cool about EMDR is it works the other way. Instead of us going back there, we start with the intrusive symptom here, use that as a target, and what EMDR does very nice is goes and gets all of those different experiences that are contributing to the intrusion of these symptoms into the perceptual system of the present. The intrusion of, not the symptoms, intrusion of the memories, of the fragments of the memories, causing the person to perceive threat where there is no danger. And EMDR does that very nicely. And in addition, the other reason why Francine is up here is she's really the first person to have articulated, and she took a lot of hits for this, and I really respect her courage for staying with this, is that she was the first person to have articulated psychiatric homeopathy. She doesn't call it that. I call it that. I think it's kind of an interesting turn of phrase, but she started from jump saying that EMDR was a method not of cure. What EMDR does is it stops the person from thwarting their own healing. And what she articulates is this, that people have, that our psyches are our spirits have adaptive resolution, that they will resolve trauma on their own. The problem is, though, that when the threat response system is going off all the time and the klaxons, whoop, 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 danger, 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 and the person is constantly in their threat response system, then the things that the system is trying to do, which I'm going to show you here in a little bit, things like flashbacks and nightmares, are evidence of a system attempting to heal itself. But my clients, when they're in their fear and they're constantly perceiving that as threatening, that it's not getting integrated. It's continuing to stay suppressed, repressed, or dissociated. And Francine articulated this in the early 90s of that's what we're trying to help. That's what EMDR does, is it gets consciousness out of the way for a few minutes while they're tracking with the eye movement or the other bilateral stimulation, and whatever is pushing on consciousness comes on forward and gets integrated. And that is more and more and more, I think that trauma treatments are headed in that direction of starting to see symptoms less as pathological and more as adaptive. And that's going to be the stance that we take as we go through today. The next person going around the circle, and then I'll go on the inside, is another one of my mentors, and he is a man. His name's Louis Tennant. He died just a couple of years ago. He was a professor of psychiatry at West Virginia University School of Medicine. I did a year-long fellowship with him and his wife, Linda Gant. And Bessel van der Kolk called Lou the Pierre Janet of the 20th century and one of the greatest trauma minds of the 20th century. And I'm another person that I am privileged to, upon whose shoulders I'm privileged to stand. And what Lou did, well, Lou really took Pierre Janet's work and built a 20th century model around it. And he, using hypnosis, he did a couple of things. And one I'm going to bring here in a little bit, as we finish up this section, I'm going to bring forward what he calls the instinctual trauma response, the anatomy of a trauma response. And more than anybody else, he has dissected what happens when a person gets traumatized. And I want to present that information to you. And I am happy to be one of his proteges and to be able to carry along that information to you. Next, beside him, moving at the 6 o'clock position, is Judith Herman. And if you've not read Judy Herman's book, Trauma and Recovery, and you are thinking about getting certified from this course, then I'm going to ask you on your honor to read that. It's a compelling text. It's what launched the field of traumatology. It was published in 1992. In 1991, we were a bunch of counselors and social workers and psychologists working with trauma. In 1993, we became one thing. We became traumatologists. Her book really brought this field of traumatic stress into its own thing. And I'll be talking to you about several things that she did. Primarily, the thing that her legacy was that she was angry a little bit when she wrote that book. I think, that's my read, was that the treatment du jour, still in 1992 when she published that book, the cognitive behavioral therapy for the treatment of traumatic stress was called, listen, you'll remember this, you've probably forgotten about it, but the treatments were called either, same treatment, two different names, flooding or implosion. I mean, how many of y'all want to go get flooded? How many of y'all want to get imploded? I mean, just the names tell you how draconian and akin to leeching that we were as late as the early 90s. We were hurting our clients significantly. You know, Vietnam veterans gave the mental health field the middle finger and said, you know, we'll we'll keep the illness because the illness is not as bad as the cure. And the folks that could, because what treatment was, it was abreactive. It was this idea that you had to have a catharsis. You had to relive over and over and over in the name of exposure. But what was happening was the psychodynamic history was contaminating all of our best thinking, and we thought that you had to have a catharsis followed by a cathexis, which would be the healing of traumatic stress. And that's what we were doing, is that we were having folks, and sometimes as early as the first session, come in and start telling over and over and over the worst parts of their combat trauma. And they would, for the ones that could endure that, they did get better. But for what happened for a whole lot of people is they got re-traumatized, and they never came back to treatment. And going up, if you look at the right-hand corner of her picture, and where it's pointing to is the white-haired, blonde-haired gentleman there. I want to mention him with her because he also, in 1992, I've got a serious bromance with that man. I love him, and his name is Anna van der Hart. And one of the reasons why I love Anna van der Hart is in 1992, I just want to kind of attribute that a whole lot of moves me. A whole lot of his work is the reason why I'm sitting here in front of this camera. Is because when I read that article, I was moved to change the way I did treatment. And I followed Francine Shapiro and a lot of other people in finding ways to treat trauma survivors that did not hurt them. And that's what Anna van der Hart wrote. And he wrote an article in the Journal of Dissociation in 1992 that said, the title of that article was Abreaction Reevaluated. And what he postulated and promulgated and brought forward was that we do not need to send trauma survivors through the weeping and wailing and gnashing of teeth to heal trauma. All we got to do is we got to integrate these charged memory fragments. And he advocated doing that through hypnosis, so it's low energy, and then the integration of these memories. And as we're able to do that, we resolve the trauma without there having to be all of this intensity, all this pain. And the two of them really, in 1992, launched a different vector that several of us have followed to develop treatments that do not re-traumatize our clients. And that's what you're going to get as a result of sitting through this course, is how to do that, how to maximize effectiveness and minimize the pain of your clients. Got a little cluster here down at the bottom, moving on around the corner to the 7 o'clock position is Edna Foa. Above her is Patty Rezik, and at the 7:30 position is Donald Meichenbaum. Those are Francine Shapiro, EMDR, Edna Foa, prolonged exposure, Patty Rezik, cognitive processing therapy, Donald Meichenbaum, stress inoculation training, and a bunch of other cognitive behavioral treatments. Those are the 4 big EBTs. And those are the founders and developers. There's a lot of other people that have contributed to it, but they're the kind of flagship folks for those 4 methods. Again, that's EMDR with Francine Shapiro, Edna Foa at University of Philadelphia with prolonged exposure. Above her is Patty Rezik at UMSL. She's retired now, University of Missouri St. Louis, and Donald Meichenbaum. I think he's at McGill in Canada. And they are the kind of champions of the 4 big evidence-based treatments. And we'll be going into those. I'll be doing a survey of those with you as we walk through those. At the 8:30 position above Donald Meichenbaum and to the left of Patty Rezik is Vincent Filippi. Vincent Filippi in 1997 did the first study with the ACEs and began to connect up the history of trauma, especially childhood aversive experiences, with negative healthcare outcomes, and I'll be going fully into that. And Vincent Filippi, and above him is a woman named Sandra Bloom, psychiatrist, who started the very first in the United States inpatient treatment for trauma survivors at Friends Hospital in Philadelphia called the Sanctuary. She developed the Sanctuary model. Some of you are familiar with that. And she really championed, for those of you who are wanting to kind of look at the history of traumatic stress and taking it, she does a beautiful book from taking trauma from the micro, intrapersonal, and starting to look at geopolitical and cultural ramifications of trauma, is her book Creating Sanctuary, which is just wonderfully written. And she was the first one to articulate the idea of, instead of asking what's wrong with you, we want to know what happened to you. She was really the champion of trauma-informed care. Her and Vincent Filippi really were the impetus to have moved forward that concept that you probably, everybody watching this has heard the phrase trauma-informed care, and that's where that was born. And then finishing this up in the left-hand corner, you will not recognize that person, but that is her name is Cornelia Wilbur. And the reason why she's there is the DSM-5, when it was published in May of 2013, one of the things that it did, which is really, it's subtle, but it's cool. If you look at criterion B3, what it says is the very first word of criterion B3 is dissociative flashbacks. And until we had the DSM-5, you do not ever see the word dissociative or dissociation associated with traumatic stress. It was with acute stress disorder, which I always thought was interesting. Up to 31 days, you had depersonalization, derealization, but somehow on the 31st day, the dissociation went away. And I think that was a lot of political, because, in the early 80s when the diagnosis of PTSD was formulated, I think that what happened was that, a lot of people that self-identified as scientist practitioners really went in the way of traumatic stress. And the scientist practitioners kind of thought that the folks that were working with dissociation were a little bit woo-woo. And there was a kind of a political separation, chasm between these two groups. And I'm really heartened that the APA, with the publication of the DSM-5, said, nah, enough of that. PTSD is a dissociative disorder. Criterion B are dissociative symptoms. And if you look at modifiers with post-traumatic stress disorder, we now have, like major depression has a modifier with or without psychotic features. PTSD now has a modifier with or without dissociative features. And Cornelia Wilbur was Sybil's therapist, if you'll remember Sybil. And what she did was that she, before Cornelia Wilbur, the treatment, sad, the treatment for multiple personality disorder was exorcism. And, as we have grown as a field, we've started to see that the reason why people have dissociative identity disorder now is because they've had heinous trauma before the age of 5 years old. And she really championed this idea of bringing forward this as a scientific and clinical treatment. And then Richard Clough and Catherine Fine took that, and Bennett Braun and Colin Ross have evolved that field into and Richard Swartz, into that we can now effectively treat those, even the worst cases of heinous trauma. You'll probably recognize at the 1130 position up there is Bessel van der Kolk. Bessel is the rock star of traumatic stress treatment. He's probably most recognized figure in the field of trauma. A lot of this course is built on his work. A lot of it is commensurate with his book, The Body Keeps the Score. You're going to find, if you've read that book, you're going to see this is the clinical application of a whole lot of what he talks about in that book. The reason why Bessel, one of the primary reasons why he's up here is in 1989, when he wrote his book. I'm seeing it in my mind. I can't. I'm going to get that and have to come back to it. I cannot remember the title of that book. I've got it in my bookshelf in my office. And what he did with that book was that he was the first person to have made the statement that PTSD is traumatic brain injury, that trauma damages brain functioning, that the neuronal sequencing is changed forever, that there is electrochemical sequelae resulting from trauma, and paved the way for us to begin to see traumatic stress more as an injury rather than an illness. Since Bessel and moving into the 21st century, more and more and more, we're seeing that trauma is adaptation to an illness, that it is a wound instead, I mean, not an illness, an injury. It is a wound, and that what's happening with PTSD, PTSD symptoms are the attempt of a system to heal that wound. And Bessel really was the kind of the first person to have brought that forward. And then in the very middle is Viktor Frankl. I'm not going to talk about him now. I'm going to save him to talk about a little bit later when we move into some material on positive expectancy. But I promise you that I will address Viktor in total. So those are the shoulders of the folks upon which we are bringing this material, except for one. I've got one more to talk to you about. And this is another one of my heroes. And his name is Joseph Fope. And Joseph Fope is the grandpappy of traumatic stress. He is the reason why we have effective trauma treatments. And briefly, Joseph Fope was a neurologist psychiatrist in Johannesburg, South Africa. Finished his training in the late 40s, early 50s, and began doing therapy with folks who were combat survivors of World War II. And if you're doing psychotherapy in the early 50s, what are you doing? Psychodynamic. So he was having those combat veterans come in and lay down on his couch in his office and talk about their dreams and their fantasies and their drives and kind of all of that stuff. And what was happening was they were getting worse, and he was getting frustrated with the psychodynamic, the limits of the psychodynamic model. And he began, all the literature at the time that he could get in South Africa was all psychodynamic. But then in the early 50s, he started discovering this maverick in the United States that was writing in a whole different way about treatment. And that was B.F. Skinner and radical behaviorism. And he got jazzed about that because Fope is a scientist practitioner. And that started making a whole lot of sense to him. Simplistic as it was, it started to look at these external motivations and begin to see that this was probably a better way to conduct research. And he began corresponding with some of the folks here in the United States that were doing that work, Skinner and others. And he was ultimately challenged and supported and encouraged to apply for the Ford Fellowship at Stanford University. And in 1955, he came to Stanford, Palo Alto, and spent 2 years there at Stanford doing the Ford Fellowship. And what he did was he set up a laboratory at Stanford. And in that laboratory, he began working with folks that had anger issues, that had compulsivity and impulsivity around anger. Joseph Fope is maybe the planet's first anger management specialist. And what he found early on was, and this is important, is he found that people that were getting in trouble with their anger, getting arrested, losing relationships,